drifting on really to the last group. It was trespassed on your territory. This was about providing information to the public and to patients.
So yeah, we had a good discussion on the subject. It struck us that the cross-government open data transparency agenda couldn't be better timed for this. We are midway through a public consultation. There will be an open data transparency strategy that will come out, and that represents a considerable opportunity, I guess, for health on this agenda. Well, thinking sort of generically around presentation of information to patients, we talked about the importance of not considering patients, obviously, as being a homogenous group, and building on the points that you were just making, we are going to need to look at a number of different avenues and a number of different ways of presenting information, perhaps thinking creatively about different vehicles for delivering it, involving the third sector, voluntary groups, and particularly areas around social networking. Mm-hmm. So connecting, using, not delivering it centrally, but stimulating some of the kind of existing communities that operate out there of patients with similar conditions and similar experiences, to start harnessing some of the knowledge and learning that operates within those communities to help inform and ask difficult questions of those providing care to them, appropriately so. And we talked a little bit about the concept of actionable information, so information that you can take in and actually do something with, make a choice, make a decision, ask a question. And we were just acknowledging the lack of evidence that currently exists in terms of what sort of information and what sorts of routes of delivery can make that information actionable, actually be translated, and it was your question earlier actually, translating that information into behavioural change in terms of populations. And we thought there was probably more work that needed to be done commissioning research around that area. We had an interesting discussion around the balance between releasing raw data and releasing some of the answers, and certainly building on some of the points that Robin was making earlier around the dangers of putting out raw data. Having said that, we didn't think there should be a single version of the truth, and we certainly didn't think that the centre should have a monopoly on the truth, and we saw the value of putting data out there, and indeed as part of that cross-government agenda, a presumption of publishing data in a raw form, albeit with significant mitigations. And the three significant mitigations we had around people doing something stupid with the data is, number one, publishing the metadata, i.e. what the data is, how it should be used, what's a good use of it, what's a bad use of it, etc. Secondly, probably producing some benchmarks for a good way of using the data, whether that come from a professional body or a reputable body to say, you know, you've got to do it better than that or add value, and that's what you'd reference back to. And thirdly, this aspect that we've debated around kite marking, though we had similar concerns about the kind of overhead, the management overhead of an assurance and audit mechanism, and potentially that's something better done by an industry itself rather than attempt to be done centrally. Getting practical in terms of kind of some things that trusts might do, obviously a systematic measure of quality outcomes in a way that is publicly available and indeed taken on by the board in a public way, in a way that's slightly more prescriptive than it is at the moment. Complaints data, so it's obligation to publish complaints data at an appropriate level of granularity. And thirdly, we talked a little bit about the staff survey, and it served us well for some time, but there was probably very significant potential for us looking again at the staff survey and using the experience and the professional ethics of a lot of caregivers to give us an illustration, ask some really pointed questions around their opinion around the quality of care that's given in their organisations. And we think there was quite a lot of work to be done there. Turning to the regulators, one of the things we discussed is, and I understand from CQC, some of the frustrations of the public in terms of the delays that occur between there being a problem and there being an investigation and something coming out formal, and people being able to see the process at a much earlier stage. And I understand CQC is about to have a new website which is much more aligned to that. But that led us to an interesting discussion prompted by a question by Robert himself around the role of national statistics. And we had sort of quite concerned. We were quite concerned about although national statistics have their value, they do create an inherent delay in the system, and there was a trade-off between timeliness and quality. So a good example of this was CQC's quality and risk profiles, which there had been some resistance to getting them out in the public domain because they wouldn't stand up to the scrutiny of a standard of national statistics, but nonetheless, you know, maybe they give 80% of the answer and they give an indication, and whether that should be a barrier to putting it out there. And we had a view that actually we shouldn't let perfection be the barrier to publication, and we should be treating people like adults and putting data and allowing them to make judgments about the validity of the information.
Very good. Huge amount of stuff in there, and thank you. Any other comments on this final point? Yeah.
Slightly related to patients and public, I was just struck by our colleague from NHS Direct was very forceful on our table about the importance of commissioning and their responsibility in terms of requiring and scrutinising the information on the quality services, because they're buying on behalf of their patients and their population. I'm just conscious myself that I hadn't given that much thought today. We've been very focused on trust, so I know we've got a seminar on commissioning coming up, and that'll be a good chance to explore, because CCDs aren't yet up and running. There's an opportunity there to start thinking through what should a commissioning group be requiring of a trust in order to assure itself and make the right challenges to people about the quality of care that they're providing for patients.
Yeah, and we have had Martin's point that they should be prepared to pay for some of that data as well, so that we get some improvement.
Just very quickly linked to that last point, and also the quality of primary care, which we know is very variable, which inevitably has an impact on when people present to hospital, etc., etc.
Absolutely, something for the NHS Commissioning Board to look at, presumably.